Okay, there we go. We are really excited about today's event. And so we'll go ahead and get started here. Our speaker is, and I asked her how to say her name, and I'll apologize up front that I may not do a great job, but I'm going to do my best. But our speaker today is Dipani Jinadasa, and I'll let her correct me while we're going. But while she's pulling up her presentation, I want to give a brief introduction of who she is. Dipani Jinadasa, and she uses she, her pronouns, is a health equity epidemiologist with the Utah Department of Health and Human Services Office of Health Equity. She sees her role as an epidemiologist activist in the health equity movement by illuminating problems of health disparities through well-presented, high-quality, actionable data. She received her Master of Public Health in International Health from Boston University and has worked in Boston, Malawi, Tanzania, India, Rwanda, and now Utah. So we are super excited that she was willing to present to us today. We'll remind you this is a collaborative effort. So as you have questions, cases that you may want to ask about, anything throughout the presentation, you're welcome for that. And I know there's some time at the end for questions as well and for discussion. So with all that being said, Dipani, will let you take the reins here.
Thank you so much, Austin, for the introduction. I'm Dipani Jinadasa. I'm a health equity epidemiologist with the Office of Health Equity at the Department of Health and Human Services. Can you all see my screen?
It looks good to me. I hope everyone else can see it.
I see it as well.
Yep, looks good.
Great. Thanks for the feedback. I just can't tell what you can see. So it's my pleasure to be here with you all today, talking about a topic that I feel very passionate about. So I'm hoping that we have a discussion. I have some questions for the end, but I also will pepper some questions throughout the presentation. So I hope this will be very interactive. And again, feel free to use the chat function if you don't want to if you don't feel like speaking, that's completely fine too. And I don't mind being interrupted for questions, so that's fine as well. Okay, so so when it comes to health equity, equity in data is key, and it's because who gets measured is who gets seen, and data are used to drive decisions, policies, and programs. And if you aren't represented in data, you can easily get overlooked. So what I'm going to talk to you about today is an effort to make sure that everyone gets seen. And in this particular example, it's by doing that through data standardization. So let's get right into it. Sorry. Okay, there we go. Sorry, can I just confirm that you all have seen the slide advance to the next slide?
Yep.
Okay, great, thanks. Okay, so in this presentation, I'm going to cover these points here. So first, I'm going to cover what are health disparities and health equity and what we mean when we talk about those terms. Then I'm also going to go over the DHHS vision to serve all Utahns, and that is the same vision that we have at our Office of Health Equity as well. Then we're going to get a little bit more into the nuts and bolts of why standardized demographic data collection, and then provide you with an example of some demographic data collection guidelines through the example of a race and ethnicity data collection guidelines that we have developed. And then we have some time for discussion at the end. Okay, so to start us off, I'm going to bring us back to a discussion that was had by the group in the part 1 of the series. And you all had talked about, people who were there talked about barriers to health in rural areas of Utah. And so I've listed some of those here that were discussed. So a big one is money that people have, or income, health insurance, access, workforce availability. And this is a big one, you know, that covers staffing and resources. Another barrier to health is language, that people's primary language that they speak, and availability of interpretation, race and ethnicity, sexual orientation, ability, geographic location, immigration status was mentioned, knowledge of resources, mistrust, experience of trauma. Someone described how that can be a barrier to accessing health resources, fear of the unknown, and housing. So, so there's a very robust discussion, and here were some of the barriers that were identified. And many of these barriers actually have to do with demographics, which are specific characteristics about a population that we can actually gather statistics about to help us inform our understanding of health at a population level. So I just thought that that was an interesting thing, that many of these barriers do have to do with known characteristics that we can then understand a bit more through data collection and creating statistics about that. So let's pivot a little bit into talking about health disparities. So health disparities are differences in health outcomes closely linked with economic, social, cultural, environmental, and geographic disadvantage. And so I'd like you to all kind of start to think about this in a little bit more relevant way. So I'm going to pose a question to the group, and please, you know, come off of mute or type in the chat. So I'd like to get a bit of discussion going. So think of a health outcome that you're familiar with, or of an area related to healthcare access. And in thinking about this health outcome, which populations are experiencing health disparities? And health disparities are not just about race, because often when there's a discussion of health disparities, we think about racial groups that are not able to access healthcare. But in your work, what health disparities do you see, and for which population? So for example, I think in the last discussion, in the last meeting, one example was given about cancer screenings and how rural populations have less access to cancer screenings than urban populations. So that there is a health disparity based on geographic status or geography. So would others be able to give some examples of health disparities that they're familiar with through their work? Okay, I see some examples here in the chat. So we have people who are part of a polygamy community. Yeah, oftentimes when there's a stigmatized community, it can be very difficult to access healthcare. Mental health for younger people, so that's a good example. Youth versus adults, youth being a population who experiences health disparities. Access to affordable food. Yes. Is there a population that you think that has less access to healthy, affordable food? yeah, the expense of groceries. So income can definitely affect, so, you know, level of income can be a dimension of health disparities for sure. Tribal communities, yeah, we definitely see in the data that various aspects of being a part of a tribal community, whether it's rurality or other aspects, definitely contribute to health disparities. Any other examples? People with disabilities, thank you, Breck. Yeah, that's a big one, and that's one we definitely want to start measuring more and being able to see more, are the disparities that people with disabilities face. One issue we see is having communities trust in the care they can receive from our clinics. Yeah, definitely. And do you think there are some populations that lack trust more than other populations? Hispanic populations? Yeah. You're thinking of your prenatal patients. Another example is people who may not have had access to higher education, understanding the process, how to apply for help to access care. Yeah, thank you, Heather. Definitely education levels are a dimension of health disparities. Small rural communities, for sure. How pain is handled differently by medical professionals across different populations. Yeah. Many women do not come in until their second trimester for prenatal care. Yeah, definitely. You can see disparities there between people who are able to access their prenatal care promptly and those who can't. Okay, well, thank you for all these great examples. Oh, there's some more coming. There's a shortage of mental health professionals, and veterans as a population are rarely understood except by other vets that understand situations. And yeah, for sure, the veteran population is known to experience higher disparity rates for various health outcomes. So these are all great examples, and all of these show how there are many different populations that can be considered disadvantaged in some dimension. And by using the word disadvantaged, I don't mean to slight that population in any way. I just mean that they have some kind of disadvantage compared to the overall population for a reason, whether it's a socioeconomic reason or social cultural reason or an experience that they've had that then due to greater social and structural factors, they're not able to access health in the same way. Okay, so that brings us to thinking about health equity. So what is health equity? So health equity, let's unpack this into the many facets of what it can mean. So health equity is a state of being in which health disparities are eliminated. So there are no differences based on disadvantage. We naturally have differences amongst us, but these differences are not based on disadvantages, and no one is denied the possibility to be healthy. So that's one dimension of health equity, is the elimination of health disparities. And then another dimension of health equity is a mindset. So it's a mindset of striving for the highest possible standard of health for all people, and as well, and I think in particular, giving special attention to the needs of those communities at greatest risk for health disparities. So if we pause and think about that for a minute, it means that we seek out those who are experiencing disadvantages and concentrating and focusing resources. And that's what this special attention kind of translates into. And that state of mind is what brings us to eliminate health disparities and promote and advance health equity. And finally, another dimension of health equity is the practice and how we practice it, which is to address inequities at the social and structural inequities at the level of social and structural determinants of health, to lead a better quality of life and advancement of all people across all systems. So let's kind of get into this a little bit more as well. So in thinking about what a health equity mindset is, which is thinking about social and structural determinants of health, what are ways that in your work you currently give or you currently address social and structural factors that affect health? If people don't mind giving some examples, that would be great. And feel free to shout out anything too.
We've talked about is that the diversity, sometimes you don't see it. And just because you don't see it doesn't mean it's not there. So if you don't have data on communities like veterans or migrant workers or LGBTQ youth or transgender youth, doesn't necessarily mean they're not there. And if we don't have the data, then we can't be there for them.
Yeah, thanks, Liz. That's a really great point. Yeah, so does anyone have examples of how you might address social and structural factors? And this might be, you know, addressing issues such as like transportation. So transportation is not a health topic, but it's a social or structural factor that is very closely linked to the ability to be healthy. And, you know, addressing barriers of transportation will address, you know, health itself. So you use a questionnaire to inquire into social determinants at each visit. Yeah, so that's, you know, a practice of working towards health equity because the first step is to inquire and understand what social determinants affect people, and then steps can be taken from there. And so while you're ruminating about that, the question about social and structural factors that you might be already addressing, can you think of ways where you apply the health equity mindset by giving special attention to the needs of communities that are facing health disparities? So in your work, are there any examples of things that are already being done that give special attention to communities who are facing health disparities? I can give you a brief example of a project that the Office of Health Disparities or Health Equity did in the past year, which was a project called Project Embrace, in which Native Hawaiian and Pacific Islander women were given resources that related to nutrition and healthy ways of living, and this program helped them meet with a dietitian and put together a plan, you know, for improving physical activity, but also other factors such as mindfulness and self-care. And so this program was specifically brought for Native Hawaiian and Pacific Islander women to specifically address some of the higher disparities that they were facing. Would anyone else like to share any examples they might have?
I know I worked with Cedar City Hospital, Intermountain Hospital, and they had a diaspora of women and families who had left an FLDS community or were leaving the geographic area. And there were a lot of concerns on the women's parts about accessing medical care with people outside of their community. And so there is actually an FLDS woman on the board at that hospital now to help make things a little more equitable and more friendly and comfortable to them, which is pretty thinking out of the box.
Yeah, for sure. Definitely representation goes a very long way towards advocating for health equity for various populations. Okay, so I'll move us along a little bit more. So I kind of wanted to cover the vision of our department and our office, to tell you a little bit about who we are and how we're coming to this work. So I'll just read it out. So the Department of Health and Human Services will advocate for, support, and serve all individuals and communities in Utah. We will ensure all Utahns have fair and equitable opportunities to live safe and healthy lives. We will achieve this through effective policy and a seamless system of services and programs. And so you can kind of see that this vision for health equity is kind of shot through the overall departmental vision. And then our Office of Health Equity mission is to advance health equity and reduce health disparities in Utah. And as well, our vision is for all people to have a fair opportunity at reaching their highest health potential, given that health is crucial for well-being, longevity, and economic and social mobility. And what I wanted to kind of point out in this is that there's this desire to serve all individuals and communities in Utah, and to be able to give all Utahns fair and equitable opportunities at reaching their highest health potential. And so, because we know that some people already are further ahead in their opportunities, being able to serve all people means that we then must focus on and give special attention to those who are experiencing disparities, and the bigger disparities as well. So, in order to understand all individuals and communities in Utah to serve them, we have to then turn to demographic data. And by demographic data, we mean characteristics of a population such as age, sex, sexual orientation, race, ethnicity, language, ability, status, and geography. And isn't it interesting that some of the demographics that are listed here are precisely some of the barriers that were identified in the previous session to achieving good health in rural Utah? So let's get into a little bit more about why collect demographic data. So first we measure the health status and health outcomes and risk factors by these various demographic characteristics. So for example, we would measure the health status of the population based on their race and ethnicity, or based on what age group they fall into, or based on their ability status. And we don't only measure health outcomes, but we also measure risk factors for those health outcomes as well. And so we'll know health outcomes by various demographic indicators and the risk factors. And so we can kind of put all that information together, which leads us to being able to detect and monitor health disparities, to kind of see which groups are not having as good health outcomes as compared to the overall population based on the various demographic data that we were able to collect about them. And then we can take that information and data about health disparities and understand what's going on, which populations are affected, and using that information, decision makers can then develop and evaluate interventions and policies to decrease the health disparity gaps between those populations. And then you go back and measure again and see how well those interventions worked. And then you kind of keep going in the cycle of measuring and evaluating. But all of that hinges on being able to collect good, high quality demographic data. And so that brings us to, why do we need demographic data standards? So standards help us promote consistent and comparable data collection on demographics across the state of Utah. If you don't have standards, then some entity collect data in one way, which won't be comparable to data that's collected differently. But if you have standards that go across the entire state, then that definitely helps compare my data to your data and to know how we're doing overall. And this also aligns with our national culturally and linguistically appropriate services, which are class standards, to obtain accurate and reliable demographic data. So this is, happening nationally, national standards. And so if we can align with that as well, that gives us even more of an ability to have reliable demographic data to work with. Uniform data collection improves data integrity and quality. And so having accurate data collection without missing data and having data over time makes it such that we have really good data available for decision making. And also sometimes data is not available at smaller levels. So the more local data may not be as good as state level data, but often decisions need to get made on local levels. So there's different reasons for that, but definitely having standards can help. And finally, standards enhance the ability to report, track, and identify opportunities to address health disparities. And as we had gone over, how you use demographic data collection to then find where health disparities are and which populations they kind of concentrate in, and then to address those through interventions that are specifically matched to those purposes of which populations are experiencing health disparities. And so our office has taken the first step towards standardizing demographic data, and we came out with some guidelines for standardizing demographic data. And so the vision for this overarching project is to standardize the way different demographic data are collected, analyzed, and reported across the whole state. So if the more partners that are bought into this and use these standard guidelines, the more comparable that the data will be across various organizations and entities. And so we're going to develop demographic data collection standards for different demographics. Also, to go along with this, we have to be able to standardize data systems to accommodate the data standard. So it's not just about changing what a questionnaire looks like, but we have to change the way that that data is then stored in data systems, and that might have to be done many times throughout a whole system in order for everything to be aligned. but the overall goal of this whole project is to improve data quality with the aim of promoting health equity in our state. So the first step we took was to publish guidelines for race and ethnicity data collection. And we started with race and ethnicity because there are federal guidelines already in place. And so we took those federal guidelines on how to collect race and ethnicity data and we adapted them for Utah and then created this guide. So then the next one we are working on are guidelines for standardizing data collection on sexual orientation and gender identity, which we refer to as SOGI. So those SOGI guidelines are in development and hopefully they will be available coming out soon. And yes, these can be found on our website. There's a link there, but at the end of the presentation, I can also point you to the Office of Health Equity website where all of our data and reports and these standards also are there. And then forthcoming are also going to be standards on collecting data on language and ability status and geography. So, rurality, or urban versus rural. So we hope that this set of 5 will kind of constitute sort of the beginning of standardizing demographic data and hope. And it's not just about creating the guidelines and having them sit on our website, but to kind of create this movement of standardizing demographic data and hope. And it's not just about creating the guidelines and having them sit on our website, but to kind of create this movement where people start to interact and use these guidelines and adapt their own systems of data collection to kind of be aligned with all of these. And if, everyone across the state is using the guidelines and aligning with them, then the comparability of the data will be really high and really good. And if these are used, for a few years, then comparing the data across over time as well will be something that we hope to improve. I will post the link in the chat as well when I get a moment. Let's see, there's a question here. I work a lot with vital records data, such as birth certificates. The data fields are largely controlled by the federal government. Can you address how or whether vital records will conform to the new guidelines? Yeah, that's a great question, particularly where it comes to data collection things or reporting that's kind of driven by federal standards. And so there's a couple ways to do this. So as I said, these guidelines are based on federal standards. So we're not trying to, we want to be aligned with federal standards from the beginning because it doesn't make sense to kind of go off and do our own thing. However, we have put in sort of additional, we've kind of gone a little bit above and beyond what the federal government requires. So I think if at a baseline, we can align with federal standards and then kind of add extra detail, then that still allows you to be kind of in compliance with how federal government needs you to report back on things like vital records. So hopefully that kind of answers that question a little bit. So, I'm going to kind of go into the example of how we developed the race and ethnicity guidelines and kind of what they look like. So you have a sense of what does it mean to have a set of standards and what do these standards look like? So I didn't want to just speak about standards. I also wanted you to see what standards kind of are and what they mean in practice. And I'm giving the example of race and ethnicity, but this kind of thing will apply across all the demographic factors that we're kind of wanting to standardize. So SOGI, language, ability status, and geography. So currently the state does not have state level demographic data collection standards. So often we turn to federal standards. But so for race and ethnicity, we developed 6 standards based on federal guidelines to help kind of guide our practice in Utah. We do know that the federal standards specifically for race and ethnicity are undergoing review, and we anticipate that there will be some changes. So we are definitely keeping an eye on that, and that may inform our own 6 standards and may change, you know, in the future if the federal standards change. But they were adapted specifically for with consideration to Utah's population. So, so for race and ethnicity, there are 6 race and ethnicity categories that are used. These come directly from the federal government. And so this is kind of the basis of the race and ethnicity guidelines, is the use of these 6 categories. I won't kind of go through them. I wanted to make sure that they were here so that people know that these are well defined. They have really specific definitions about the origins of people, and that comes from the federal government. So here are the 6 standards, and so I'll go into them in a little bit more detail. So let's start with the first one, which is self-identification. And this means that you know, historically, people weren't always allowed to self-identify. So this really crystallizes the fact that a person's race or ethnicity is identified by them. And so that's the self-identification standard. Then the second standard are the minimum categories for use of race and ethnicity. So there are 5 minimum race categories that must be used, and a 6th category for ethnicity. And this may be up for review in this federal review. So we may see some changes to these minimum categories, but for now, this is what they are. And I'll talk a little bit about additional granularity. So, you know, once these minimum categories are used, it's possible to find ways to kind of go deeper into each category through additional granularity. So the next standard is the question format. And here is one place where we have diverged a little bit from the federal government's standard. So for the federal government, they ask the race question separately from the ethnicity question. And by that, I mean, first you're asked, what is your ethnicity? And then you can answer Hispanic, Latino, or not Hispanic, Latino. And then you're asked, what is your race? And then you're given 5 race choices, as well as some other race. But these standards, that standard was created about 20 years ago. And since then, there has been a lot of research that has shown that this combined format standard gives you a much higher level of data quality, because when you ask race and ethnicity in 2 separate questions, there can be a lot of missing data, especially among the Hispanic Latino population trying to answer the race question. And so when it's combined like this, there's a lot more completed data that you get. And we also anticipate that the federal government may turn to a combined format as they do their review. But at the moment, this will be a little bit of a challenge for data systems to handle, because currently race and ethnicity are collected in 2 separate questions. And so, as I said, it's not just a matter of changing the questionnaire, the data collection questionnaire, but you also have to think of the repercussions of what that means for, you know, the actual system that handles storing the data, and also the repercussions of reporting, because some federal reporting requirements require statistics on race and then separate statistics on ethnicity. And so following these standards will be guidance on how you can collect data in a combined format, but still report it separately. But that's outside the scope of this discussion. But I want, it's good to know that that is something that is in development that will follow. So the next standard is to allow respondents to select multiple designations of race or ethnicity if they want to identify a multiracial heritage. And a few iterations ago of census data collection, it was not possible to identify multiple races or ethnicities. You had to pick a primary race, but in this standard, you are able to mark all that apply or select all that apply. And there's no separate multiracial category. So if a person is multiracial, they would mark, 2 or more of the single races. Then the fifth standard is additional granularity. So we encourage additional granularity beyond those 6 minimum race and ethnicity categories, as long as that additional detail can be aggregated back to the minimum standard set of race and ethnicity categories. I have an example here of what that could look like. So, so these are all the 6 race and ethnicity categories with additional detail. So additional origin detail in them. And this is just an example of what it could look like to collect additional granularity when it comes to race data. Okay, I'll move on for the sake of time, but I find that that's kind of a very interesting discussion there. And then the final one is that agencies may add an option of other so that people can write in their race or ethnicity if they don't identify with any of the minimum standard categories there. But any written in responses do then have to be coded. And so that can add an extra burden of to the data collection. So if we tie this all together, here's an example of what that could look like. I think it's a little bit blurry, but so all the 6 standards are kind of encompassed in this one template. So so it's first is self-identification. So the person that fills out this form is the person about whom the information is about. So that's the self-identification standard. Then we have the minimum categories are all represented here, those 6 minimum categories. Then we have the combined question. So it asks you, what is your race or ethnicity or both in one single question. And then we have the additional granularity for each of those minimum categories as well. So each of those minimum categories have, further details, and you can even write in a detailed race or ethnicity in there. Also, the standard of being able to identify your multiracial heritage is in here because you're able to check all that apply. And then finally, there's an other. So some other race or ethnicity you can specify. So it all comes together pretty nicely in a template such as this. Sometimes when you think about standards, it might seem more complicated than it actually is. But this is just an example, and this example is available in those guidelines. And so we have taken steps to make an implementation guide to go along with the guidelines. So this has some information about designing data collection instruments. Oh, thank you, Christine, for posting that. Yeah, that's a link on the chat to where the data collection guidelines, as well as the implementation guide can be found. So yes, in the implementation guide, we also explain for people who are hesitant about their data being collected, especially demographic data such as race, how to explain confidentiality, privacy, and purpose. And this is, we feel, will be very important when it comes to the SOGI data collection as well. What this implementation guide does not cover at the moment is guidance on data analysis and reporting, which will be a very important piece, especially in the areas where we might depart a bit from the federal government standards, but reporting still needs to be done in a way that is acceptable to the federal government. And so I just kind of wanted to kind of wrap this up and bring us into our discussion by saying that as we better understand people who live in Utah, we can better advocate for, support, and serve all Utahns in our public health and healthcare and service provision capacity. And it's our understanding of all Utahns through a robust demographic data collection practice that will best inform effective policy and a seamless system of services and programs so that all Utahns will be able to enjoy a life where health equity is happening. And so that brings us to a discussion here. So just to start off, what are people's impressions of having and using standards for demographic data collection? Do you think that this is feasible, across the state for various entities? And are there any challenges that you can think of to doing this?
I'd be interested in knowing what, oh, here's something in the chat. Hard to implement on the back end for analysis. I love the standards and I like how they've been done. It will be hard to implement though on the back end for analysis.
Yeah, and I think that's where part 2 of this discussion comes in, is to how to analyze the data that come in. Anytime something is done differently, anytime something is done in a new way, it has knock-on effects that definitely pose challenges for data analysis. So yeah, I appreciate that comment. It is a potential challenge for rural facilities who have limited resources to collect data. Yeah, that's a great point, because this doesn't happen just, with a, it shall be done sort of wave of a wand. It takes dedicated resources, funding to address changes to data systems. So yeah, thank you. That's a great point. For instance, Suzanne Smith says, for example, if someone marks 3 races, where will they fall on a data table of outcomes by races? Exactly. So in sort of an older way of doing things, you would then have to do some kind of statistical imputation method to kind of assign them a primary race. But that then erases all the detail that we're going for. It's kind of going against the spirit of why we're trying to have more and better multiracial data. And so there are different data approaches on how to analyze and report out multiracial data. Some of that will be informed and governed by federal requirements or grant requirements, but others where there's a bit more flexibility, there's more room to be a bit more thoughtful on how that can be done. And these are exactly some of the issues that I will try to grapple with in a data analysis and reporting part of the implementation guide. Any other feedback about how you think it will work for, you know, the way we do public health and healthcare in Utah to have these standards, and any other challenges that go along with it?
Dipani, did we address, there was a question earlier in the chat box about vital records and if they'd be expected to conform to the new guidelines?
Yeah, so what I will say is currently at the moment where we are, these guidelines are simply recommendations. There's no mandate to use them. There's no force of law behind them, or nor force of policy behind them at the moment. So currently they're just there as a set of best practices and recommendations based on research of how things might be done. So I think, you know, until there may be a force of law behind them, there may not be enough reason or motivation or to change how things have been previously done. So yeah, so I will say that there's no mandate here at the moment. So you might kind of carry on doing things how you have done them before, but if there is any room to consider adding, you know, some of the things that come out of these guidelines, I think that's where we are at this stage. But we do definitely hope to generate some movement around this by starting at, you know, with ourselves and seeing where we go with being able to you know, implement these guidelines with ourselves. And then if there's any other comments or questions at all, I'm happy to answer them at this time. And I can.
If you didn't notice in the chat, the Office of Health Equity shared links to some of their documents and their publications so that you have that. There was another question I think may have gotten missed. I know it's hard to keep track of when you're talking. Give me just a minute.
Yeah, you can go to healthequity.utah.gov. That's our homepage for the Office of Health Equity. And from there, you can get to where we have our data and our reports.
I think we
can find